Okay, so I'm just going to give an introduction to polysomnography. A few of you guys were introduced to this during our Compumedics training. Obviously, I know Sarah and Brent have been doing it probably longer than I have. So it'll be a little more difficult just over like online compared to an in-person training, but this will give a good introduction. And I'm actually using slides that were from Harry and Shane. They're sleep technicians at the University of Chicago. And then also Brent had made an EEG training presentation. So I took some information from his slides as well. So thanks to those guys for this presentation. So to start off, does anybody know what polysomnography means? Okay, so basically it's a multi-parametric test that is used in the study of sleep. And if you actually break down the word polysomnography into its Greek roots, you have poly, which means many, somno stands for sleep, and then graphy means to write. So it's really just a way for us to take something physiological like sleep and then use a device to kind of translate it to a computer where we can, you know, look at it and really just kind of look at sleep and look at kind of the different stages and stuff like that. So the objectives for today, we're going to just assess the sensors that are used in PSG recordings. We'll go over how you actually measure the head for a hookup. We'll go over how you apply the sensors for a hookup. And then at the very end, we'll just go over biocalibrations and then look at a few examples of different PSG recordings. So sensor types, we have a few different types. We have EEG, and these are really measuring the electrical signals from your brain. You have EOG, which measures your eye movements. Oculo stands for eyes. EMG is measuring muscle movements. So in a normal PSG hookup, that'll be like your chin muscles. And then ECG is obviously measuring the electrical signals from your heart. And today I'll just be going over a normal PSG hookup that participants would wear throughout the course of the study. On the first night of the study, we will do a sleep disorder screening, and that involves extra sensors that look at respiration, you know, snoring, stuff like that. But we'll leave that for a later presentation and just go over the basic PSG hookup today.
Yeah, quick plug that the original creator of this slide deck, Harry Whitmore, will actually be presenting in June on how to sleep score. So yes, thank you.
Oh, cool. Cool. Yeah. So basically the American Academy of Sleep Medicine created a manual, and this manual tells you how to score different stages of sleep. It gives you technical specifications, and really all of these specifications are made to ensure that anyone who is recording sleep or looking at a PSG recording is looking at the same thing. You can imagine how difficult it might be if one lab used one technique and another lab used a different technique, how comparing you know, study results would be difficult at that point. So why is PSG used in general, but I made it more specific to our lab? So obviously to evaluate different stages of sleep, we can see, you know, when participants spend the night in our lab, what percentage of the night they were in stage 2 compared to REM sleep. PSG is used to diagnose sleep disorders. Like I said, on the first night of our study, we will put sleep disorder equipment on. Most commonly breathing disorders, we're looking for different apneas, periodic limb movements, narcolepsy, and other parasomnias. And then an important one is in sleep deprivation or circadian misalignment studies, which is what we do in our lab. For example, in C2CM, we're doing a simulated shift work protocol. So when participants are awake during the biological night, they can get tired a lot. And so we use PSG to really confirm that participants are staying awake when they should be awake and then sleeping when they should be sleeping. And then lastly, objective measures of sleepiness. So a month ago, I presented on MSLTs and MWTs. For CTCM, we're going to be using MWTs, and we're really going to be using the PSG for this. So we asked them to maintain wakefulness for 20 minutes while laying in bed, and we will be looking at the PSG computers, looking at their brain waves, and really looking for a K complex or a sleep spindle. And this is indicative that the person fell asleep. And so that's when we'll know, okay, the test is over. This was their sleep onset latency, and we need to send someone in the room to make sure that they stay awake for the remainder of the 20 minutes. So PSG methods, really our goal is to amplify tiny electrical currents, whether it's from the brain, the heart, your eye movements, into an interpretable graph. So we'll fill electrodes with conductive paste, and we will put them on your scalp, on your face, chins, eyes, and then we will connect all of these electrodes to an amplifier. And in our case, this amplifier is called the siesta. And then this siesta then translates a signal to the computer and really writes out these recordings, which is something that we can interpret, something that we can analyze. So that's kind of the purpose of the PSG recording. And if we go into the actual electrodes we use, the most common one we use is this gold cup, and it is connected to a wire that you then plug into the siesta. But obviously you would clean all of the surfaces on the scalp and the face that you're going to connect these electrodes to. And then you'll either glue them on if it's in your hair, or you'll tape them on if it's, just on your skin, on your chin or something like that. So this is the most common type of electrode used. There's also snap-on electrodes, and these are what we use for obviously the EKG electrodes. So you have a little snap-on electrode. Again, it's connected to a wire that will plug into the siesta, but you snap it onto an adhesive pad and you just stick that onto the body. So these are like the two electrodes that we will use for C2CM. So impedances an impedance is a measure of the contact between the electrode and the skin. And really our goal is to make the impedances as low as possible. Right after you do a hookup, one of the first things that you're going to do is turn on the PSG computer and go check your impedances to make sure they're all low, because a low impedance will mean that your signal, your recording will be easily interpretable. And so the American Academy of Sleep Medicine manual requires that all electrode impedances should be below 5,000 ohms. Sometimes the chin electrodes are a little tricky to either stay on and get a really low impedance. So in the past, I've used 10,000 ohms for chins, but for our purposes, I'll talk to Sarah and Josie and kind of see what we want to do with that. So hookup prep, this is super important whether you're, doing a practice hookup in the lab or doing a hookup during a study. You always need to prep beforehand. It'll just make your life so much easier. So you want to get all of your electrodes that you'll need. You'll fill them with 1020 paste, which is a conductive paste. And really this is just helping make that impedance low. You'll need gauze pieces, alcohol wipes, and all of this is for cleaning the scalp before you actually attach the electrodes. Your measuring tape, pencil, hair clips, those will all help with doing your measurements before you actually attach electrodes. All of the electrodes on your scalp are actually glued on. You have tape for your face electrodes, ECG pads, your siesta, all of that. So a little preparation goes a long way. You can see this is a really nice prep. You have all of your materials, everything's laid out nicely. Your life will be miserable if you try to do a hookup and your table looks like this. And I know all the materials kind of seem confusing, but once you actually are in the lab doing a hookup, it'll make a lot more sense. And we'll go through kind of what you need for each step as we go through this presentation.
Did you prep that, Shannon, just for us?
No, it was already
that was already in there.
Yeah, it was
from
already
Harry?
in the presentation, but it looks really nice. I would
That's amazing.
just like that. Okay, so now we'll go into actually measuring the head. So we use the 1020 system of electrode placement. And basically this system uses 4 major landmarks on the head and then just different measurements between those 4 landmarks. And really this is, again, an internationally recognized method to describe the location of electrodes on the head. So the 4 landmarks, you have your nasien, which is this indentation between your nose and your forehead. Your inion, which on the back of your head, if you like move your finger up from your neck going up your head, you'll feel like a bump and then it'll start to flatten out. And that's really where your nasien is. And then you have your left and right preauricular points, which are just 2 points right above your tragus on your ears. So those are kind of the 4 main points, and the measurements are just everything in between those. So in this 1020 system, you have a bunch of different letters and numbers, and it can look really confusing, but it actually makes a lot of sense. So F stands for frontal. And so this is right here, and this is your frontal lobe, right? It corresponds to the brain. It's right in your frontal lobe. FP is frontopolar, and that's more on your forehead. The T's stand for temporal, right? So your temporal lobe is on the side of your brain. C stands for central, so that's really just like in the center of your head. P is parietal, and then O, occipital, obviously matches with your occipital lobe in the back of your head. Odd numbers are always on the left side of your head, and even numbers are always going to be on the right side of your head. And that's something that is helpful to remember when you're doing a hookup. Just to remember, like if you have an ECG1 and ECG2 electrode, you know, you remember like, oh, odd numbers are always on the left side. So, and then the last thing to mention is as you get further and further from this central line on your head, the numbers increase. So we can see that in these Fs, it's F3 and then F7. So that's kind of how things are labeled in this measuring system. Here's just another look at, you know, your nasien, your inion, and then this like your preauricular points. Okay, so for measurements, there's really 6 steps, and you can make multiple markings within each step. So the first step is you're going to measure from the nasien to the inion. And then something that something that you do during the hookup is you always just leave the tape measure on the head for each step. So you can ask the participant to help you. So you would like put it on their nasien and you would ask, hey, can I have you hold this for, you know, a couple minutes? And then you would wrap the tape measure around and you'd get that full length. And then you have to do a bunch of calculations, like what is 10% of this full length? What is 20% of this full length? And so you would leave the tape measure there, and then you would mark 10% up from the nasien, and this would be FP. So that's kind of like your mark right on the middle of your forehead. And you always mark perpendicular to the tape measure. So if the tape measure is going there, you would mark perpendicular to that. So we're still in step 1, and then you would mark 10% up from the inion, so just on the back of the head. You would mark 50% between the nasien and inion, and this is CZ. So that's really the central point on the top of your head. And then you would mark 20% forward from CZ, and that would be FC. And we actually have a worksheet that we use for every hookup, and basically it'll tell you what percentages you need for each of these measurements. It'll tell you exactly where to mark, what the marking is, whether it's CZ, FC, stuff like that. So it can sound super confusing, but if you just follow the worksheet, it makes a lot of sense. And another thing to note is we don't put electrodes on every single marking we make on the head, but we have to make every single mark to then like get the markings that we actually need. Sorry if that's a little confusing. Okay, so that was all step one. So that tape measure would have stayed on and we would have made those, 5 markings on step one. So then you would take the tape measure off and your second measurement would be from the left preauricular point to the right preauricular point. Again, leave the tape measure on, and then we're making a bunch of markings based on percentages. So at 50%, you're gonna cross at CZ. So we already made 1 mark and now we're gonna make a cross. And then you do 20% from CZ to the left, you're gonna mark at C3, 20% to the right, you're gonna mark at C4, and then 10% up from the left and right preauricular points, you're gonna mark at T3 and T4. So those are the 5 markings that you're gonna make for step 2. So step 3, you're gonna do the circumference of the head. So you're gonna go from that FPZ right in the middle of the forehead through T3, through the back marking that we made earlier, OZ, and then through T4 and back to the front of the head. So you can see why we need to make that T3 and T4 markings to then get the circumference. And then again, we're just doing percentage measurements or markings. So 5% to the left of that middle marking is FP1. Another 10% to the left is F7. And then you do the same thing for the other side. So you go right to FP2, make a mark, and then right to F8 and make another mark. We're still part of step 3 in the circumference measurement. You would make a mark at OZ at 50%. And again, this is gonna make a cross at OZ. And then you're gonna mark 5% to the left of OZ and make a mark at O1. Okay, so like I said, going over this over a presentation is really confusing, but it's just giving a nice glimpse into what measurements actually look like. Okay, so step 4, this is the bonnet, which we call it the bonnet measurement because it's like right in the front of your head. I guess it looks like a bonnet. But you'll measure from F7 to F8, and then at your 50% mark, you're gonna make a cross at FZ. Step 5, FP1 to C3, at 50%, you're gonna make a mark at F3. And then step 6, F7 to FZ, you're gonna make a cross at F3. So you can see that in some of these steps, there's like 5 different markings that you have to make, but in these last few steps, it's really only 1 marking at 50%. So this is it. Once you do all these markings, that's the end of measuring the head. And it's important because all of the spots where we actually glue electrodes, you have to have a cross. So you can't just have 1 marking because then you wouldn't have an exact point of, putting the electrode on. So we have all of our crosses. We only put 6 electrodes on the scalp. And these are the spots. We do CZ and FZ, and then we do F3, C3, C4, and O1. And something to pay attention to when you start, practicing measurements is all of your measurements should be in a really nice grid. So if you think like we just made crosses, but if you were to extend the lines down, they all should connect and line up. And if they don't, that maybe you missed a step or mismarked something. So just visually being able to look at your marks and be like, okay, yeah, all these line up, that looks pretty good. So you'll have 6 that we glue to the scalp. And then we have 6, what I refer to as face electrodes. So we have 2 on the eyes, 2 on the chins, and then 2 we put on the mastoid bones behind the ears. And then obviously we have our 2 ECG electrodes. So technically total, we have 14 wires going from the body to the siesta. Okay, does anybody have any questions about measurements? Okay. Perfect. So now we'll go into actually applying the electrodes to the scalp or the body, wherever you're putting it. So once they've been marked, you have to now clean all of these sites. So first you would take an alcohol wipe and you would, wipe right in the middle of the cross that you made. Then you would take New Prep, which is, it's just another conductive gel that really helps clean the scalp, and it helps that connection between the electrode and your skin. So you put a little New Prep gel on a Q-tip, you then clean the site, and then you take one more alcohol wipe and you clean the site once more. So now you're ready to actually attach the electrode. So remember, this would be done during your prep. So you would already have all of the electrodes filled with this 1020 paste. Again, the 1020 paste is just a conductive paste that will help lower those impedances. So actually applying it, obviously your skin would be cleaned, and you want to press firmly down on the electrode. You don't want to press so hard so that all the paste just flies out the side of the electrode, but you want some to come out the side. Some will obviously come out that little hole on the top. You just want to make sure that it's firmly in contact with the skin. And then on our scalp electrodes, we use tensive glue. So you would take a little piece of gauze and you would put a glob of the glue on the gauze, and then you just press down the gauze on top of the electrode. And this really helps keep the electrodes in place. Obviously, for some of our studies, they're going to be wearing PSG for multiple days. And so it would be really annoying if these electrodes were just falling off every 10 minutes. So the glue really helps them stay in place over the course of the study. For the eye electrodes, for the left eye, you want to go 1 centimeter to the side and 1 centimeter down. This is in this picture, and we just tape it. We don't glue these electrodes. And then on the right eye, you go 1 centimeter over and 1 centimeter up. So you can see this electrode is kind of above the eye here, while this electrode is a little lower than the eye. For the chin electrodes, you just kind of, I don't know the best way to describe this. Sarah, you had a good one with, do you want to chip in on how you describe this?
Yeah, the way I remember it is I imagine the person having a butt chin. And so if you put the electrodes on the butt cheeks of the butt chin, then that's the exact place that you want the electrodes. So for whatever reason, that's easy for me to remember.
Okay. Yeah, perfect. And these ones, I've seen it done both ways. You can tape it in place. I've seen people use ECG pads, and just because those are, the adhesive is a little better, and these chin electrodes tend to fall off quite often just from talking and moving around. So you can use ECG pads to hold them in place. Or if a guy has like a lot of facial hair and maybe a thicker beard, you can actually glue those ones as well. So it's just something to kind of think about when the participant comes to the lab and thinking about what might work best for that person. Okay. And then these are the 2 ear electrodes. Obviously, if you feel behind your ear, you feel a nice bone, and that's your mastoid bone. And so that's where we put A1 and A2 electrodes. And remember, odd numbers will always be on the left side of your head. So that's something that's easy to remember for this. And obviously all sites will be cleaned the same. Even these face electrodes, you use the alcohol wipe, the New Prep, and then another alcohol wipe. And then your 2 ECG pads, you place the one on the right up here below your clavicle, and then the one on the left down here near the bottom of your rib cage. So that's kind of the placement where all of the 14 electrodes go. Just a tip when you're doing hookups, you want to run all of the electrodes from the front to the back. And this is really just for organization. It's really annoying for participants if electrodes are just like dangling in front of their face, or they're getting all caught in everything. And so when we run everything from the front to the back, we can actually put all the electrodes in what we call a spine, and it just keeps everything organized. It makes it much more enjoyable for the participants, given that they have so many electrodes attached to them everywhere. Okay, does anybody have any questions about actually putting the electrodes on?
When I was going through using the paperwork that we have, I noticed some of them, they never had a specific spot where they told you to make the first cross, but they were indicating that you were making a second cross already. So I wondered if some of them, when you were measuring like circumference, if you're just automatically assumed you have to make crosses for certain ones.
Yeah, so on the worksheet, there are some that tell you make a cross here, and you do that because, you know, later in the hookup, you're not going to come back around on some measurement and cross it. Okay. There's both. Some you only make one mark, and then later in the hookup, you'll end up coming back and crossing that mark. But others on the worksheet, it tells you, hey, just make a cross here. And when it tells you to make the cross, like, for example, I think on C3 and C4, it tells you to cross them. And so you just really want to line that up with, you know, your marking up here. That's what I was saying, like visually look at the head and you can see where the line should meet up, and that should help you make like the exact crosses.
Shannon, do you want to mention, because our example on here does not have hair, which is actually, this is funny because this is my friend Abe from the University of Chicago as the subject, but do you want to talk quickly about what it looks like and feels like when someone has really thick hair and you need to get in there?
Yeah, so I guess I almost enjoy doing hookups on people with longer hair because I can actually take their hair and part it where I need to. Mm-hmm. So like for girls or guys, if they have long hair, I will always make them have a middle part, which some people hate, but I'm like, I'm sorry. And that just helps you. So you're not trying to put electrodes and then there are parts over here, and like visualizing that is super weird. So part the hair however you need to, like grab the hair, pin it up. We have like little hairdresser clips, and that can help you, like when you're cleaning the site, you can like pin the hair side to side. Like with our Mito participant this past time, she asked us to braid her hair because her hair was so long, and just with all of the electrodes, it just kept getting super tangly. So yeah, it can be more difficult with thick hair or longer hair, but you definitely can use combs, you can use clips, anything to help you kind of, you know, hold the hair back wherever you need to.
Yeah, and that's, as you get more experience, you'll start to see more what we're talking about, but especially people with really thick hair, if you think of your own part, it kind of poofs up. And so then it becomes important when you're trying to press the electrode down, and then the tensive glue actually is also serving to push that hair down so that the electrode can actually come in contact. But that's also what the paste is for, is to create that contact, even if the electrode is poofed up and sitting a little bit up on the hair. So thinking through the whys of this, especially with PSG, I actually think if you know why certain things are there, you can really troubleshoot better. So, you know, if you're getting a bad reading because someone's hair is raising the electrode off of the scalp, you can scoop a little bit more paste so that it's, you know, it can be a little bit messy and gunky, but that might be what you have to do to make sure that the electrode is actually coming in contact via the paste with the scalp.
Right.
And then Shannon, I know you mentioned that this might be confusing, but the awesome thing is we're recording this. So this is exactly the type of thing that people can, as they have more experience, they could go rewatch or even watch and pause as they're practicing, and things like that. And then are you going to talk a little bit about what the different electrodes are picking up? I don't want to jump in if you're in, like, what are reference points versus actual data collection?
I don't have that, no, in this presentation, but we definitely could talk about it.
Yeah, just so that people also, and for our recording and for our sister lab that we send our recording trainings to understand what the reference points are, and the fact that, you know, the bony, where you're placing them on your A and C and central, you want to actually be essentially 0. Like, that's why they're the reference points, if you want to talk about that a tiny bit.
Yeah. And I don't know if I'm the expert on this. So Sarah, if you have any input on this too. So the FZ and CZ electrodes, these are your reference and ground electrodes. So if I remember correctly, all of the other electrodes are kind of like dependent on these 2 electrodes. So this is something you can consider, like, when you're troubleshooting a PSG, if it looks really bad. So if you're looking at impedances and every single electrode is like over 100K for impedances, you're like, okay, that must be something wrong. There must be something wrong with one of these 2 electrodes, because it's very, very rare that all 14 electrodes would go bad at once. I guess, are you talking about like how we reference it, like O1 is referenced to like A2 or stuff like that?
Yes, but also the fact that, so that's awesome what you said, because you're totally right. You know, if you see all of a sudden the whole recording go bad, you need to, you know, there's sort of a triage for checking. It's really not going to be, it's less likely to be all of your electrodes and more likely to be the one that they're, you know, all referencing to. But also the fact that the A's behind the ears, these are also reference points. So these, the placement of these are less important, because you're not necessarily trying to find a specific landmark on the brain itself. You're actually just trying to have a bony, you know, section, so that this should be very low electrical activity. So it's used as a reference point to subtract out kind of basal electrical activity. So this can be another place where you can see issues, like if your occipitals go bad, and they're, you know, you can kind of check your A's and things like that.
Yeah, and everything's always cross-referenced. So like C4 would always be referenced to A1 because it's on the opposite side of the head, and like C3, F3, O1 are always going to be referenced to A2. And you'll see that in the PSG trace. If like all 3 of these electrodes have a horrible trace, you'll see that they're all referenced to A2, and then you can go in and be like, okay, I need to replace the A2 electrode.
Yeah, understanding what things are referenced to can, exactly what Shannon said, can let you know what to check first. That's it. I think that's all I wanted to just to point out the referencing.
Perfect. Okay, so after the hookup, this is what our little, I know this picture is small, but this is what our siestas look like. On the left side here, this is where all of the electrodes will get plugged into. And each of the plug-in ports are labeled. So they'll be labeled like O1, C3, C4, reference ground. So you'll know exactly where to plug which electrode into. Learn how to use that spine. It's just like a long black tubing that you can wrap around all of the electrodes, and it just helps keep everything organized. You'll put batteries in the siesta. You do need a screwdriver to, it's on the back of this white portion, and that's how you put batteries in and take them out. Turning the siesta on, it's a little tiny button up in the corner of the siesta, and it can be really difficult to actually turn on. Sometimes you have to use your pinky finger because it's so small, but something that we definitely want to remember is never use the screwdriver tip to like try to turn it on. You might think like, oh, this is small, I can just press it down. But in Boulder, we actually have had people use the screwdriver and then the button like disappears in the siesta. And these devices are really expensive. So we just want to remember to take care of them as best we can, both ourselves and then reminding participants just to care for them as much as they can, you know, never holding the siesta by the wires or trying not to drop it all the time, stuff like that.
Yeah, I want to reiterate that because it's, you know, the longer you have a piece of equipment in the lab, the more it can start to be taken advantage of. And, you know, the fact that we have to use a screwdriver to take off the battery cover, you know, we just have to be so careful because just like Shannon said, in Boulder, you know, the screw that's used to close that battery cover gets stripped if it's mishandled and overused, and then all of a sudden you have to start duct taping the siesta, which is gets worse and worse, and then gets all gummy and disgusting looking, and it looks, even if it's not dirty, it looks really dirty, and it, you know, it's giving the wrong impression to our participants. And so yes, these are now the most expensive pieces of equipment in the lab. They're approximately $30,000 each. So these need to be very, very well cared for and treated like the precious little babies that they are. And they're kind of light purple. They're very pretty, which I didn't even know. Apparently that's the original color of the ones that we're used to, but they got so discolored over the years. So yes, we want to take really good care of these devices.
Yeah, even like sometimes glue or like the paste can get on the outer black cover. So just like wiping that off with a cavi wipe or alcohol wipes, like really just try to keep them clean because they can get like pretty nasty if you don't take care of them. And then this participant doesn't want to hold some nasty little, you know, so we just really want to make sure that we care for it as much as we can. Okay, so now we'll go into BioCals real quick and then look at a few examples of PSG recordings. So biological calibrations are really just a series of actions that we ask the participant to perform, and it just lets us, it shows us that all of the sensors are performing correctly. So BioCals are always done right before a participant goes to sleep. It's like the last thing you're going to do in like the last 3 minutes that the participant's awake before you turn the lights out. Sometimes you can do them before, actually you do them before MWTs as well. So those are the two times that we'll do BioCals for C2CM. The participant will either be seated in their bed or lying down if they're about to go to sleep. And then we give them a series of instructions, and this is where we will use our new intercom system. So they'll be in the room with the door closed, and you usually do BioCals through the intercom system. So the first two BioCals that we do is we ask them to please keep your eyes open for 30 seconds. And I always say, please try not to blink. And then you'll do, please keep your eyes closed for 30 seconds. And when you give each of these instructions, you will make a tech note in the PSG recording. And so these are things that then someone coming back to score the PSG recording can reference these BioCals and see, okay, this is what it looks like when, you know, their eyes are open, when they're asleep, stuff like that. And the purpose of these first two BioCals are to establish the presence or absence of alpha rhythm. And so when you close your eyes, you often see alpha rhythm through that O1 electrode, which is pretty cool. We will see an example of that in just a few slides. The second two BioCals we ask are without moving your head. We ask them to look left and right a few times. Without moving your head, we ask them to look up and down a few times. And these two instructions are really to make sure that those eye electrodes are working and that we can see all of these eye movements. And again, we'll put a tech note in the recording when we give these instructions. And then lastly, we would ask the participant to blink 5 times slowly and then, you know, clench your jaw or grit your teeth for just a moment. Again, looking at examples of what an eye blink might look like. It can look different in different participants. So this is why we do these BioCals, so that it can be a reference. And then the chin one is to make sure those 2 chin electrodes are working. Okay. And then when you're doing sleep disorder screening, there's a few more BioCals that you do, like, you know, take deep breaths or flex and point your feet. We're looking at those leg sensors. So there's a few more with sleep disorder screening, but these are the main 6 that you will do for most of the BioCals. And then obviously, if we put electrodes on someone, we have to take them off. The glue that we put in the hair just comes out with water. So I like to get like a little transfer pipette tip and just kind of squeeze some water on it. You want to make sure that you're being gentle taking them off because it can be uncomfortable. You don't want to rip someone's hair out. You can use alcohol wipes to like clean all the red marks off their skin, to clean any extra glue if you need to. Obviously throw out trash. We do have an SOP for exactly how we clean the electrodes. We soak them in soapy water, soak them in bleach. So just follow that to clean the electrodes, and we'll show you how to do that if you're actually coming in for PSG training. And then put everything back where it belongs, hang the electrodes. Ellen and Sophie and I think we put hooks behind the door in like the office space. So you can see a bunch of electrodes hanging on hooks there, put the batteries back in the chargers, and then return the Siesta to the correct location. So for certification for our lab, those of you who are interested or are going to be trained on EEG, you have to do at least 3 full hookups. Your certification hookup has to be in dim light. And this is because in our study, you might have to complete a hookup in dim light, and it does make it more difficult doing all the measurements. It makes it harder to see. So we just want to make sure that we have practice and we're able to do that in dim light. If it's your practicing hookup and it's like your first or second hookup, you can do it in normal light. But if you're trying to get certified, you have to do it in dim light. All impedances have to be under 5K. Again, chins might be 10K. I have to talk to maybe Sarah and Ellen about that or something. All electrodes have to be within a 0.5 centimeter of where they should be. So a PRA or a grad student will check your measurements and make sure that everything is within a 0.5 centimeter of where it should be. And then you actually have to complete the entire hookup in 50 minutes. So usually I say that measurements should take you about 15 to 20 minutes. And then gluing will take you the rest of the time. If it's your first full hookup, it'll probably take you like 2 hours just because you're getting used to everything, and that's okay. But for your certification one, you wanna get it done within 50 minutes. And usually, or I know for C2CM, because I've been working on the flow sheet, you will have longer than 50 minutes to complete these hookups, but it's just making sure that you're sufficient in being able to do hookups in a decent amount of time, because sometimes you don't have a ton of time. No assistance, obviously, and then a grad student or a PRA has to verify and sign off. Does anybody have any questions about getting certified? All right. And we just have a few more slides. These are just cool examples of what the recordings look like. We'll go through a few. So up here, we're looking at the 2 eyes in the blue traces. This red one is the chin activity. And then it might be difficult to see, but you can see how all of these are referenced, right? So F3 is referenced to A2, C3 is referenced to A2. So that's kind of what Josie and I were talking about earlier. So this is a very awake, alert person. It's a very high frequency. The waves are pretty close together. There's a bunch of muscle activity, eye blinks. You can tell that this person is very awake and alert. This is a drowsy one. So this is an example of the alpha activity that we see. Also, their eyes, you're seeing not a lot of eye blinks, so you might think that this person might have their eyes closed. They're still awake because the frequency of these waves is still high, but you do see that alpha activity. And alpha activity was always described to me as tall grass, but I always got confused because I'm like, it all looks like tall grass to me. But if you actually start sleep scoring, you'll start to see differences. And this is a good example. You can clearly see the difference between, you know, this trace and that trace. This is an example of stage 1 sleep. So what I'm looking at is the frequency is a little bit lower. So, you know, it's really close together here. The waves start spreading out a little bit more. You can see there. Again, you can't see a bunch of eye blinks. So that's how I would kind of classify it as stage 1. You're seeing theta waves. Stage 2, this one is a little bit easier to tell what stage you're in. You see this really nice K complex, and yeah.
Real quickly, if you just go back to stage 1 and you see the eyes, you can actually see in stage 1, 2, you see what's like the eyes actually start to roll. And so that last bit in that frame, you can see that the eyes are rolling there a bit. And if you see more epics of stage 1, you'll see that eye rolling continue before they go into deeper stages as well. So that's also an indicator of
Yeah,
stage 1
slow
as
rolling
well.
eye movements are a good indicator. This one, I thought it was kind of hard to tell, but some you really see like this wave going really like up and down in a slow rolling eye movement. But yeah, that's a good point. Thanks, Brent. So stage 2 are your K complexes and sleep spindles, right? These like bursts of activity are sleep spindles. And this is the stage that you're looking for during an MWT. So while that person is sitting in bed trying to stay awake for 20 minutes, you're going to be looking at the PSG recording and looking for these K complexes or sleep spindles, because that's going to tell you, okay, yeah, this person is asleep. I need to wake them up. And this is the end of the MWT. Stage 3 and 4, slow wave sleep. You can really see it's low frequency, high amplitude waves. You can see it throughout all of the traces. This one's pretty easy to determine if you're sleep scoring. And then REM sleep. It goes back to theta waves. And then the main points in here is you have muscle atonia during REM sleep. So you're not going to see any muscle activity in those chin electrodes. And then you're going to see the eyes almost look like they're blinking. So you might think that they're awake, but they're not. These are just rapid eye movements that occur during REM sleep. And that is all. Does anybody have any questions on PSG in general, measurements, the hookup, anything like that?
I do want to chime in that we now have a bunch of styrofoam heads that people can take home if they want to bring home a tape measure or red pencil so that they can start learning how to do these measurements. And you can refer to this video as well. We'll probably do some sort of in-person training. We'll see maybe small groups or whatnot so that people can be in person, learn from our lab experts of how to do it and take it home and practice.
Yeah, and just being certified in EEG or PSG is something really cool to have on your resume. And also if you're interested in sleep scoring, that's another really awesome skill that you can gain from the lab. I think all of it is pretty cool. So I would highly suggest doing both of them if you can.
Yes, I agree. And thank you, Shannon. That was a really excellent presentation and gave us also a nice taste for what scoring might look like, which we'll dive deeper into when we have Harry come and give us a scoring training a little bit later this summer. Corinne, did you have a question?
I just want to say too, there's also a recording of when we did it on Raj and we did the hookups. That's what I was watching when I was practicing on the styrofoam heads. So that helps too. If anybody else is practicing at home, that gave me a little more of an idea of what I was doing because you could see a little bit where she was making the markings. So that was helpful.
That's awesome. Thank you for reminding us of that. Yeah, even there's little tricks of how to hold the tape measure and how to kind of teach your hands how to work. So that would help with that. And then yes, the in-person training for sure. Cool. Well, thanks everybody. Thank you, Shannon. Like I said, again, really spectacular. And what a wonderful resource we now have within this recording in the lab. Raj lost his video, but he gave a little thumbs up if you can see. So he says thanks too. Awesome. Okay. And then let's see. Ellen, if you want to go ahead and stop the recording, we'll be good for the